Thank you very much. And I think it's afternoon by now. Good afternoon, everyone, and thank you for this opportunity to speak about the Far West LHD Direct Access Colonoscopy Clinic, so DACC for short. Melissa Cumming is our Director of Cancer Services, and she's the project lead, and I'm actually the project officer and the clinical nurse consultant. So I think a great place to start would be, what is DACC? So it's actually an innovative nurse-led clinic that fast-tracks people with a positive fecal occult blood test, or FOBT, who meet a set clinical criteria through to colonoscopy, thus avoiding the waiting time to see a gastroenterologist. And those fecal occult blood tests, or the FOBT, they're commonly known as those bowel kits that are sent out to you every 2 years after you turn 50 and before you turn 75, and they can actually detect minimal amounts of blood in your bowel motion, which may be indicative of early bowel cancer. And after you've had a positive FOBT, the recommended investigation is a colonoscopy. So just a small introduction about the Far West. We're actually the second largest geographical LHD, and we have a population of just over 30,000. And we actually rely on a fly-in, fly-out gastroenterology service from Adelaide, and we are the only provider of colonoscopy services in the Far West. So we actually have 4 gastroenterologists that visit us, and they visit us on a rotational basis, and so we're actually provided with, say, 2 days clinic per month and also 2 days scoping per month. So background into our DACC project, the national guidelines actually recommend a person with a positive FOBT attend their first specialist appointment within 30 days of referral from your GP, and then have a colonoscopy performed within 120 days. Also, the National Bowel Cancer Screening Program is increasing their participation up until the year 2020, so that's every person over the age of 50 will receive a bowel kit every 2 years. We also knew there was an excessive wait time to colonoscopy in the Far West, and we had a limited gastroenterology service. And the delay for people with a positive FOBT in the Far West was the waiting time for their first appointment with a gastroenterologist. And we actually knew that if this access point barrier could be reduced, our colonoscopy list actually had the capacity to accommodate additional cases. So our project aimed to reduce waiting times for people with a positive FOBT, improve access to colonoscopy, provide an efficient, equitable service within the national guidelines, also ensuring the right care at the right time and also by the right person, and reducing morbidity and mortality through cancer prevention. So our method began with some data collation and investigating systems and processes. We engaged our key stakeholders, and we reviewed other LHD models, and we actually went on a Hunter New England site visit. We also developed a positive FOBT database, and we also addressed system issue gaps prior to moving forward, and they were things like we needed to prioritise our Category 1 people on our waiting list on clinical indications rather than their referral date. And we also had to correct our RFA categorisation. So just to give you an example to highlight the waiting times we faced in the Far West, we received a referral for a 46-year-old lady who actually had a positive FOBT showing signs and symptoms as well. Now, if DACC was a model at the time of her referral was received, she would have been suitable. However, she actually waited 454 days to be seen for her first appointment. So during our pre-implementation of the DACC model, we obviously set our clinical criteria. We developed a suite of patient information literature, clinical forms and flowcharts. We also introduced the new service to the GP practices, and then built the referral form into their IT platforms. Then we created a generic email and an IP clinic. So our first DACC clinic was held back in September last year, and to the end of June we've actually received 128 referrals, and 70 of them were DACC suitable. So just over half were able to be seen in a fast track service. And a couple of graphs to show our results. So the blue is pre-DACC and red is post-DACC. So you can see our first graph there, if our light's working. Not at the moment, that's okay. So the first graph actually shows the number of patients waiting to see a gastroenterologist. So at the beginning of our project, we actually had 582 people waiting for an appointment with a gastroenterologist. And as of June this year, we've actually reduced that down to 104. And our Category 1 patients have decreased from 161 down to 7. And then you can see the second graph there is, you can also see there was a significant reduction in the waiting time as well. We've actually decreased our Category 1 waiting time from 705 days down to 88 days. And importantly, prior to DACC, actually no patient in the Far West was seen within 30 days, nor was their scope performed within 120 days. And to date, we've actually had 86% are now seen within 30 days. 74% of the patients attend their colonoscopy within 120 days. And 72% of those direct access patients actually had precancerous lesions removed. And previous delays actually could have had dire consequences for these patients. And also just to highlight a case, the post-DACC, after our post-DACC implementation, we received a referral for a 28-year-old gentleman with a positive FOBT and also showing signs and symptoms. His sibling actually passed away from colorectal cancer at the age of 29. Now, through the direct access clinic, he was actually seen within 15 days and his colonoscopy was performed 38 days later. And the findings from his scope, he actually had 10 precancerous lesions as well. So I'm sure, as we all imagine, a very, very different outcome for this young gentleman if he had waited the 454 days prior to the direct access clinic. And our outcomes to date, also we decreased the appointments and colonoscopy waiting times in all categories. All our patient experience surveys were positive. We actually created positive partnerships both internally and externally. And we now actually offer video conferencing to patients in those outlying areas. So that really reduces travelling time, as you can imagine, is very vast in the Far West, and the cost to those patients as well. A local contact between GP and gastroenterologist has also been extremely valuable, considering that our gastroenterologists don't live locally. And patient monitoring to actually ensure they return their RFAs has also been very valuable. And cross referrals to other services has also been great, for example, dietitians. Other LHDs have actually adopted our project for use in their own local contexts. And from the outset, our project was actually evaluated by the University Department of Rural Health. And actually, due to the success of our project, the Cancer Institute has refunded us for another 18 months to build upon this direct access clinic to include models of surveillance as well as follow-up patients as well. And we actually aim for DACC to be embedded into our core service delivery after the funding has ceased. And just to finish up, some acknowledgements, especially to the Cancer Institute for their grant to complete this project, and also to Hunter New England, Orange and Adelaide, and the Hunter New England, Orange, Royal Adelaide Hospital and the University Department of Rural Health, and the key stakeholders, of course, for their contribution and their generosity in sharing their knowledge and resources. And that's me. Thank you, Richard.
Thanks, Kellie. That was amazing. Just to repeat, that's 705 days down to 88, I believe.
In 2 years.
In 2 years' time. Great. Okay, I'm going to kick off with my own question. Is it possible that this model would scale to other remote areas in Australia?
Yes, it is scalable to remote areas, and obviously the larger areas have their own direct access clinic. It all began up in Hunter, New England, so depending on the size of your LHD is how big your direct access is, but it's very adaptable to all LHDs.
Okay, any other questions?
Did you use your data, collected data, or did you send it back to Cancer Institute or any other part, or just kept locally, I mean?
No, the data has been given back to the Cancer Institute because that is we're a grant recipient, yes.
Okay, good.
I was just wondering how easy you found it to embed the referrals into the GP practice systems.
It was okay. It was something a little bit innovative because I went down an email track. We're used to a fax service, so that was something. And I think moving forward, that's the way they should all be sent out. So it was bit, it was a good starting point, and it was fine. You know, once you sell to the GPs that their patients are going to be seen a lot sooner, they were very much on board.
Thank you.
Thanks for your great talk, Kellie. I was wondering, with colonoscopy, it's not just a cancer services responsibility, often within an LHD. And can you talk about the kind of leadership that was required to get that up and running?
Well, for us in the Far West, our waiting time on the colonoscopy waiting list wasn't the problem, it was to the first appointment. We have actually a very innovative num in the theatres, and if she sees that list is growing, what she will do is she'll get in contact with our visiting gastroenterologist and say who is available, and I've got these dates available, and we can catch up on our list that way. So we're very lucky. We do have a very good team. Thanks everyone. Thank you.